This is Dr. Zebczynski. This presentation on psychosocial assessment in older adults is from Information in Advanced Practice Nursing in the Care of Older Adults, 3rd edition. The psychological evaluation of the older adult includes assessment of basic needs such as autonomy and independence, dignity, credibility and respect, identity and individuality, communication and belonging, and touch. Think of these older individuals in terms of Erikson's psychological stages of development. Stage 8 is integrity versus despair, and integrity is facilitated through maintaining these basic needs of autonomy through touch. Older adults are diverse. They're diverse in their health status, in their social and their environmental support systems, in their financial security, and in their cultural and their personal philosophies. Things that occur in adults that can often affect their lives include retirement and role loss, changes in daily routine, from that of being a breadwinner to suddenly being the homebody, the loss of a spouse, or especially the loss of close friends. Not uncommon to find people in their mid-80s who are very sad because they are maybe one of very few that are left in their group of friends. Family problems. They may have children or grandchildren that have addictions or other types of problems. Relocating can be very stressful, even if they're just downsizing or moving to a retirement community. Financial problems, maybe from the loss of a spouse or a job or retirement income that doesn't keep up with the bills. There is no single evaluation tool for psychological health that can be applied to all older adults because older adults are a diverse bunch of people. They tend to be private and reluctant to discuss what's going on with them, and oftentimes physical symptoms may be the only expression of the psychosocial dysfunction that we see. The relationship we develop with the patient as a provider is most important. The better the relationship, the more forthcoming a person may be in telling you what's going on. Sometimes the physical symptoms, such as a headache or shortness of breath or fatigue, can be the outward manifestation of something that's going on inside, such as anxiety or depression. There are measures of psychological health that we look at. Cognition is the first one, and that's mental status. Think about your awake, alert, and oriented to person, place, time, and situation. That's cognition. Affect is the emotional or the feeling side, and often that's represented through anxiety or depression, but sometimes a person may have a flat affect. They may have no emotion on their face, and it's our job to kind of work with them and find out what's going on. The psychosocial assessment is an interactive process. It is performed at an initial encounter whenever you first meet your patient, and then annually or sooner, depending on what your results are. The Welcome to Medicare examination and the annual wellness visits are a really good place for you to look for this information. The Welcome to Medicare examination is done once for a person who has recently started Medicare Part B, that's the physician side, and it is a review of the past medical history, medications, any psychiatric history, cognition, changes in behavior, review of potential depression, risk factors, substance use, suicide, abuse, or neglect. There is a nice little handout that I've included for you so that you can look at it, and this is a link to the Medicare site so that you can see for yourself. Also, there's some good billing information included for you so you can see what you would be billing for one of these visits. It is really important for us to ask people about specific symptoms and not kind of go around them, but ask, how are you feeling? And if they say, I don't care one way or the other, that may be a sign of apathy. Sadness, ask them directly. Depressive symptoms, is there a lack of energy, a loss of interest in doing what they used to do, decreased ability to concentrate? Is there agitation? Is there sleep disturbance? Determining capacity. Capacity is a functional determination. Either an individual is or is not capable of making a decision within a given situation, such as perhaps the individual has been ill, and maybe as a provider, I am suggesting that they look at going into a long-term care setting. Perhaps they can't take care of themselves the way they used to. Competency, on the other hand, is the ability of an individual to participate in legal proceedings. That means to be able to show up and represent themselves and sign their own name on legal documents. As an NP, I can determine decision-making capacity in patients, but it involves doing a complete mental status assessment, and it involves an appraisal of the patient's culture, educational level, health literacy skills, and their ability to articulate the issues of concern. Agitation is a change in behavior. It is considered a neuropsychiatric symptom of dementia. It can be manifested as aggression, hyperactivity and irritability, excessive motor activity or verbal and physical aggression that can be associated with emotional stress. It occurs most frequently in people with cognitive impairment or dementia. Contributing factors, cognitive impairment, also sensory impairment, social isolation, chronic bed rest, pain, environmental triggers. Think of some things like sensory impairment, someone who's by themselves all the time. They have no social interaction. It's a quiet place, and maybe noises set them off, or the television sets them off, or they are in pain and that sets them off. Some symptoms include crying, screaming, arguing, pacing, repeating questions is common, or shadowing a caregiver. Management of agitation depends on the manifestation. In other words, how it's presenting. Are they violent? Are they talkative? What is it exactly? What is the behavior we're trying to allay? It's good to do some diagnostics. You can do a CBC, you can do a complete metabolic panel, urinalysis. Oftentimes a UTI will flip somebody over into agitation. You can do an EKG. Then treat any infections or acute medical conditions. Review the medications. Often these older people have polypharmacy. They're on many, many drugs, and these drugs interact. And so look at them. Is there anything new they've been put on that could be responsible for causing an agitation? Then we want to treat agitation. We want to help the person lessen their symptoms. So antidepressants are helpful in decreasing agitation among those who are depressed or who are anxious and have paranoia. Antipsychotics such as risperidone, aripiprazole, or olanzapine for severe agitation with aggression. Antiepileptics can help, but the short duration is best because of the side effects or long-term adverse effects. And cholinesterase inhibitors are also helpful. They can be used long-term. And behavioral interventions. There's a mnemonic here called TURTLE. This is something that you can teach the caregivers as well. TURTLE means take charge, understand possible triggers, reassure and redirect, take away distractions, leave the area with the patient, emphasize and evaluate. Probably the worst thing we can do is to get annoyed and yell and shame a person who is agitated. Anxiety disorders are common among older adults, and they are linked to cognitive impairment, disability, and decreased quality of life. Identification and prompt initiation of treatment is important. Anxiety does not tend to get better on its own. Signal symptoms include excessive worrying, talking about the same thing over and over again, restlessness, fatigue, difficulty concentrating, irritability, muscle tension, sleep disturbances. Mom says, I just can't get my mind off of Harry, okay, or Jenny, or whoever, or I just keep worrying about that bill and whether it's going to get paid and if I have enough money. Physical manifestations may be evident, such as headache, chest pain, palpitations, shortness of breath, dizziness, sweating, and GI upset. The management of anxiety begins with a complete history and physical, ruling out any physical problems that could be manifesting as anxiety, doing some labs to rule out some conditions. You can do a CBC to rule out anemia. You can do a CMP to look at their electrolytes. You can do a TSH to make sure their thyroid's functioning. You can use tools such as the Geriatric Anxiety Inventory or Geriatric Anxiety Scale. These are going to help you figure out how severe their anxiety is. The goal here is to improve functioning, decrease distress, and give these people relief from the symptoms of anxiety. If you've suffered from anxiety at all, you know what it feels like to carry that inside you. It's very uncomfortable. So the treatment can be first line, the selective serotonin reuptake inhibitors, or SSRIs. Those include sertraline, brand name Zoloft, escitalopram, brand name Lexapro, or citalopram, brand name Celexa, or the serotonin and norepinephrine reuptake inhibitors such as venlafaxine, brand name Effexor. Another very good tool is cognitive behavioral therapy, and you probably have to refer the patients for that. So medications can be used together with CBT or separately. You can use either the medicines or CBT. Try one and then the other. Anybody who presents with suicidal ideation or expresses a desire to either harm themselves or other people needs to be referred or sent immediately to an inpatient psychiatric facility for treatment, management, and treatment. Bipolar disorder is a mood spectrum disorder, similar to major depressive disorder, but it's differentiated when the person has their first manic episode. This can occur at any age. It's most common in the adolescent, younger adult age group and less commonly diagnosed after age 50. But there are a lot of people out there who have never been diagnosed and have had it maybe lifelong. Contributing factors: at least one relative with bipolar or a unipolar depression. Adverse childhood events can contribute, as well as traumatic brain injuries. You're going to see these people when they come in for depression. That's what brings them in. Sometimes when we see people in a depression and we give them an antidepressive, if they are bipolar and never diagnosed, this may actually activate their manic episode, either euphoria or irritability. Symptoms during a manic or a hypomanic phase can be thought of as dig fast, distractibility, indiscretions, grandiosity, flight of ideas, activities are increased. There's no need to sleep. sleep deficits, and they're talkative, pressured, or rapid speech. If you've ever spoken to someone, actually listened to someone with pressured speech, it's as if their words are being propelled out of their mouths, just one right after the other. Symptoms during the depressive phase or can also be looked at with another mnemonic called SIGI CAPS. Sleep disturbance, interest is lost, or their word for that is anhedonia. They have guilt feelings, thoughts of worthlessness, energy changes, they're fatigued. They can't concentrate, they don't have much of attention span, their appetite changes, their weight changes, they may gain or lose weight, and they have psychomotor disturbances such as agitation or retardation. They may have suicidal thoughts. So you can see that this depressive phrase kind of matches a depression. In order to diagnose it as a depressive phase, you require 5 of these symptoms over a period of 2 weeks. The mood disorder questionnaire is helpful in determining bipolar disorder, but it's not specific to older adults. You can use a geriatric depression scale. The goal here is remission of symptoms and improvement of functionality. When people are in a depressive state, they're not very functional, and when they are in a manic state or even in a hypomanic state, they don't have a lot of meaningful function. Assess the need for hospitalization. First-line treatment for late life onset of mania in people with bipolar disorder are mood stabilizers. These are very effective and include lithium and valproic acid. Antipsychotics are also helpful. Risperidone, brand name Risperdal, quetiapine, brand name Seroquel or olanzapine, brand name Zyprexa are helpful. You'll need to do some labs before you start. Patients on lithium are going to need initial renal, cardiac, and thyroid function checks before starting. The adverse effects of lithium are tremor, hypothyroidism, rash, weight gain, and renal impairment. We advise patients against taking NSAIDs, thiazide, loop diuretics, or ACE inhibitors. These are going to affect lithium levels and impair renal function. Lithium is an excellent drug, but it's hard on the kidneys. It is excreted by the kidneys, so we have to keep an eye on their labs. Patients on valproic acid need to have liver function tests and CBCs. Adverse effects of valproic acid include weight gain, hepatotoxicity, pancreatitis, sedation, and thrombocytopenia. This is a list of commonly prescribed drugs called atypical antipsychotics. You've seen this list in earlier slides. An atypical antipsychotic is also known as a second-generation antipsychotic. The original or first-generation antipsychotics included haloperidol, which is Haldol, fluphenazine, which is Prolixin, chlorpromazine, which is Thorazine, among others. And these drugs worked very well, but long-term use, which is often indicated, caused irreversible side effects. These side effects are known as extrapyramidal side effects, or EPS. These are drug-induced movement disorders. For instance, the inability to sit still, involuntary muscle contraction, tremors, Parkinson-like symptoms, which include stiffness, shuffling when walking, pill rolling with the fingers, and mask-like facial features, and tardive dyskinesia. This is an abnormal, repetitive facial movement, such as lip smacking or poking the tongue out. Second-generation antipsychotics are less likely to cause extrapyramidal side effects, which is terrific. However, they are widely prescribed and they can and do cause metabolic syndrome. Metabolic syndrome is a group of findings that includes increased waist circumference, dyslipidemia, that can be high triglycerides and low HDL, fasting hyperglycemia, and elevated blood pressure. When you are reviewing your med list in the clinic, look for these atypical antipsychotics and make sure you're screening your patients for metabolic syndrome. Then, if you have any of these findings, treat them according to guidelines. That's diet, weight loss, statin therapy, antihypertensive, and management of elevated glucose. Delirium is a change in mental status. Often manifests as confusion, disorientation, and agitation. Any medically ill person can develop delirium, and older adults are more prone to developing delirium, especially when they are ill, because their physical and mental reserves are stretched. They're not resilient as they once were. Many things can cause delirium. There's a big list here. Metabolic changes, infection especially, cardiac problems. Medications are a big cause, as are toxins such as alcohol, illicit drugs, or alcohol withdrawal. Unfortunately, delirium is often missed. We may expect delirium at times in a hospital setting. In the office setting, it can be a change in the baseline behavior. Symptoms can be subtle or what we call subclinical, such as restlessness, anxiety, irritability, distractibility, sleep disturbances. The sleep-wake cycle is kind of off. Reversal or fragmentation of sleep. Perhaps they've got their nights and days mixed up. Lability, that is laughing one minute, crying the next. Anxiety, fear, depression, irritability, anger, paranoia. Delirium must be treated in order to prevent damage to the brain. This is really something very important to be aware of. I visited a friend who had been hospitalized for a heart surgery, and on entering the ICU, the nurse said, "You know, he's acting kind of odd today. He's kind of angry and a little paranoid." Well, I looked at his situation. He was in an ICU post-op after a big chest surgery, pain medicines, all kinds of medicines, and I suspected delirium. In talking with him, he was obviously agitated, he was scared, and he was convinced the nurses were lying to him. And he said to me, "If you tell me different, I will believe you because I know you." I told him I believed him and that I thought the nurses were being honest with him. I then asked the nurse to please call the provider and report this as delirium so that he could be treated right away. The point here is that I knew this person and I understood that he was not acting like himself, and given the context of his situation, I suspected delirium, and he was treated. Knowing your patient is important. The other thing is listening to your patient's family members or caregivers, because they're going to notice some changes in your patient as well. Dementia is not a normal part of aging. It occurs more frequently in those with advanced age. Some 40% of individuals will have some dementia by the age of 90. However, dementia is often overlooked or it's diagnosed late. The DSM-5 cites evidence of cognitive decline from previous level of performance in one or more cognitive domains. Think complex attention, executive function, making decisions, learning and memory, language, perceptual, motor, social cognition. These may be noted by a caregiver or a clinician. Diagnosis is based on substantial impairment in cognitive performance, preferably documented by standardized neurocognitive testing. These cognitive deficits interfere with independence in everyday activities. They do not occur exclusively in the context of delirium, so delirium is not necessarily a component, and they are not explained better by another mental disorder such as major depressive disorder, schizophrenia, and so forth. Alzheimer's disease is the most common cause of dementia. Cognitive changes include becoming lost in familiar places, forgetful of recent events, people, their names, difficulty with communication and language, like trying to find a word or not remembering a word, becoming unaware of a time or place, and change in mood and behavior, such as increased anxiety, irritability, or frustration. There are a number of types of dementia. The most common is Alzheimer's disease, and that's the one that we'll focus on most. In diagnosing dementia, you need a good history, and then perform some cognitive testing. There are a number of screenings that you can do. The Mini Mental Status Exam, or the MMSE, is easy to administer. The Montreal Cognitive Assessment Exam, or the MOCA, that includes the clock drawing test, which is pretty specific and sensitive. Often there will be signs. There may be aphasia, where they're trying to find a word or try to get a word out. They may have apraxia. This is forgetting how to use familiar objects, such as a hair comb or using a cell phone. The dexterity is there in their fingers, but the brain can't connect to the task and use the object for what it's meant for. There may be anosia, which is not recognizing familiar people or objects, and there is often a decrease in executive function or the ability to make a decision. It's important to investigate an underlying disease process. In your testing, you may want to look at a complete metabolic panel, a CBC, vitamin B12, very important for memory, a thyroid stimulating hormone, and brain imaging is indicated. Other tests should be guided by clinical history. Be suspicious of a sexually transmitted disease, such as syphilis or HIV, if there is evidence to support that. Look at Lyme disease. Ask about environmental exposures. Also ask about environmental or occupational exposures to heavy metals. This is the Mini Mental State Exam, and you can see that there are 5 different sections. One is about orientation. There's also registration. That refers to naming objects, and then asking the patient to say them after you at a certain period of time, and how many trials you give them. Attention and calculation, such as counting serial 7s, 7, 14, 21, etc. And recall, asking them to recall those objects that you told them earlier. And then language, naming objects, closing their eyes, writing a sentence, and copying diagrams. This is scored out of 30 points, and it's best used with patients who have had a high school education. Any score of less than 24 is indicative of some kind of dysfunction. In interpreting the MMSE, the score is out of 30 points. The interpretation of the score is based on the educational level of the person, and you can see here that anything less than 24 is considered impaired. This is the Montreal Cognitive Assessment, and this is scored also out of 30 points. And you can see here that there are a number of sections: naming, memory, attention, language, abstraction, delayed recall, and orientation. And the clock drawing test is part of it. This is a description of the clock drawing test. Most people can draw a clock, and this can be used in combination with other screenings. It's very simple to administer. The aim here is to see if there's any loss of cognition, and This can detect mental decline, as people with dementia often have problems reading traditional clocks. This test is of executive function. This is working memory, and then self-control. That means actually having to sit there and draw the clock. It's very methodical. We talk about assessing functional decline, and this includes two areas. One is instrumental activities of daily living. Those are the things such as working, shopping, cooking, finances, taking medications, driving, maintaining the home. These tasks require multiple complex steps, such as planning, in order to execute them. Then you have activities of daily living. This is such as dressing, bathing, toileting, eating, ambulation, or transferring. These require less planning. In treating Alzheimer's disease, memory-enhancing medications may help slow the progression of memory loss. It's best if these are started in early stage Alzheimer's, as they can help the person stay in that stage longer. Ultimately, this may allow the person to stay home longer and live independently. Clear expectations need to be established with patients and family, because these drugs will not reverse memory loss. No drug can. There are two types of drugs that we prescribe, and those include the cholinesterase inhibitors, which increase the amount of acetylcholine in the brain, and the NMDA receptor antagonists. The cholinesterase inhibitors include donepezil, which is Aricept, rivastigmine, which is Exelon, and galantamine, which is Remenil. And the NMDA receptor antagonist is memantine, Namenda. These all have equal effectiveness. Additionally, antidepressants, antipsychotics, and mood stabilizers can be added when needed for behavior. Let's take a look at a case study. A 76-year-old male presents with a history of confusion and bizarre behavior. His wife reports short-term memory loss over the last year, but significantly worse over the last 2 to 3 months, marked by atypical behaviors. He's been having conversations with his deceased brother. He's packed up his truck with food and firearms and driven through the neighborhood trying to find his family farm. He's been obsessed with keys, having made 20 different keys to the front door, and he calls a locksmith because he can't find a key. He's been trying to get his neighbors to do things for him for a large amount of money, such as give me a ride for $100. His past medical history includes hypertension, hyperlipidemia, atrial fibrillation, and hypothyroidism. His prescriptions include amiodarone, amlodipine, apixaban, atorvastatin, levothyroxine, and metoprolol XL. He scored an MSE score of 20. His labs, his complete metabolic panel was notable for some changes in his BUN and creatinine. Probably has some chronic kidney disease here. Vitamin B12 level was nice at 1776. And look at that TSH. It's over 200. He had a CT of his head, which showed chronic left corona, radiata lacunar infarction, and mild small vessel ischemic disease. Now, mild small vessel disease is expected in a person of his age. What we know here, though, is that his thyroid is not being controlled. He's very hypothyroid. His TSH is very high. And what we found out was that he was not taking his thyroid medicine consistently. And when he was taking it, he was taking it in the afternoon with his other meds and foods rather than on an empty stomach. This was corrected, and at a follow-up 8 weeks later, his abnormal behavior had improved, and he had an improvement in his MMSE to 30. So keep in mind that as the primary care provider, you may be the first person to hear about this interesting behavior. Let's look at the second case. A 72-year-old man presented with a complaint of memory loss. He recently retired and he has noticed he's been more forgetful. He forgets names, he forgets events of the day before. He and his wife report he still functions well. Still drives well, including driving the camper to Florida 2 weeks ago for a trip. He still manages his own medication and manages the finances for the couple. So there's no real functional impairment noted. There's some memory impairment here. His past medical history includes hypertension, for which he takes lisinopril. The MMSE score was 22 out of 30. His labs, the CMP was within normal limits. His TSH was 0.98, which is normal, and his vitamin B12 was 728. Anything between 500 and 1,000 is considered normal. MRI of his brain was unremarkable. There was no evidence of prior stroke, trauma, or tumor. He had mild diffuse atrophy, which is appropriate for his age. But he's also taking Benadryl 50 milligrams at night for sleep. Which classes of medications can affect cognition? Benzodiazepines, antipsychotics, anticholinergics, narcotics, or all of the above? If you answered all of the above, you are correct. And here's a clinical pearl. Anticholinergic drugs and benzodiazepines are most likely to affect cognition. These drugs are commonly prescribed but should be avoided in older people, and they include diphenhydramine, Benadryl, very common antihistamine used for sleep, hydroxyzine, Vistaril, also very common, used for nausea and also for sleep. Oxybutynin, which is Ditropan, which is used for overactive bladder or BPH. Dicyclomine, which is Bentil, which is used as an antispasmodic for IBS. In this case, diphenhydramine is a strong anticholinergic drug associated with causing memory loss. The diphenhydramine was discontinued, and he improved his sleep hygiene by decreasing caffeine and taking melatonin about once a week. When he returned 4 months later, the MMS he had improved to 29 out of 30, and he and his wife reported resolution of the memory loss. The diagnosis here was polypharmacy. This is the third and last case. A 63-year-old man presented to the clinic with a history of being repetitive, difficulty organizing time, hard time focusing. He was diagnosed with ADHD 6 months prior. This man has a PhD, and he scored an MMSE of 24, which in someone with an advanced education, 24 is something to be concerned about. In the last year, he and his wife have noticed that he's had difficulty in keeping up with job-related tasks. He's been actually relying on his assistant to come to meetings with him to help him remember what to do, what to follow up on, what to keep track of. He has difficulty remembering appointments and needs reminders to take his medication. His past medical history is significant for hypertension and hyperlipidemia, for which he is medicated. He had a Montreal score of 15 out of 30. His labs, TSH was 2 and vitamin B12 was 713. Both were normal. Let's look at the MRI of his brain. The report read mild generalized cerebral atrophy, mild chronic vessel ischemic disease, chronic left basal ganglia infarct, and the punctate foci of gradient susceptibility artifact within the cerebral and cerebellar hemisphere are seen with, and here it is, cerebral amyloid angiopathy. Cerebral amyloid angiopathy is microhemorrhages characterized by amyloid plaques, and it can be associated with Alzheimer's. This patient meets the criteria for early stage dementia with impaired cognitive test. He had a 15 on the MoCA and a functional history of decline in the instrumental ADLs, those that are involved with planning and executive functions. The MRI shows evidence of an earlier stroke, which was identified incidentally. He didn't know he had it. He has vascular changes that are consistent with age and the stroke, and the amyloid plaques, which are consistent with Alzheimer's disease. So he is actually diagnosed with a mixed Alzheimer's and vascular dementia. Now, although this may be beyond the scope of what you do in primary care, when you read an MRI of the brain, you can be looking for these particular things. In this case, he was started on donepezil, 5 milligrams of Aricept daily. Memory loss is not the same as forgetfulness. Now, patients will often bring up their problems with remembering things. They may report that they can't remember what they had for breakfast or what they did yesterday. They may even say, I just can't multitask like I used to. Well, here are just a few facts. Multitasking is a myth. Our brains are wired to do one task at a time. And we have told ourselves that we're multitasking, even though what we're doing is moving very quickly from one task to the next, that it seems seamless. And we can do this effortlessly when we're younger. But as we get a little bit older, there's a little bit of a delay in the process of recalling, remembering, and even moving on from one step to the next. I mean, think about sitting at home watching a game show. It may take longer to shout out the answer to a game show question. For these folks, we can offer cognitive testing to help allay their fears of memory loss or to figure out if that's what's going on. Remember also that stress, loss, grief, illness can affect our ability to pay attention. An example is a patient with dementia who experiences the loss of a spouse. The event doesn't make the dementia worse, but it may affect their ability to pay attention. Or think about yourself in school trying to figure out how to work, go to school, raise a family, drive children here and there, etc. Over a period of time, you may find that you just don't remember some of the details anymore. And that part of that is a response to stress. So what exactly is polypharmacy and why is it important? Well, the definition is taking 5 or more medications, including over-the-counter medications. That's not a good definition, and for a number of reasons. A definition of polypharmacy needs to address medications that may not be necessary or may in fact be harmful to a patient. Older patients with chronic diseases take multiple medications to control those disorders, but so do younger patients with diabetes, hypertension, hyperlipidemia. Even children take multiple medications. There are a lot of expectations of the healthcare system. When we diagnose something, it's expected that we're going to treat it, and usually that means adding a medication. The clinical guidelines contribute to polypharmacy because they're disease-specific and they're goal-directed. We treat an illness to a target. The geriatric population is not well represented in these guidelines. They're good about adding meds, but they're not so good about pulling back medications. Some examples are an A1C. The target of the A1C for an elderly person is inappropriate at 6.5. And the ADA guidelines have actually changed so that we can now treat older people closer to 7 or a little bit above 7. Or surely you've seen people that have been sent home on a PPI and they're on them for years. And we know that PPIs have side effects over a long period of time. So it really does come down to the patient's expectations. Their outcomes, the focus of their outcomes are somewhat different than those of a provider. Many patients want to live their lives without burdensome symptoms, or they want to control symptoms and improve functionality. Those are their outcomes. So it is up to us as providers to look at the different drugs that people are on and to understand that taking multiple drugs is a risk. Some of the risk is that there is a drug-to-drug interaction. Another is that there are adverse drug reactions and there are side effects. The more drugs we take, the more potential reactions that a person can have. So a geriatric patient's ability to handle these reactions are more limited than, say, a younger person. And as you can see from the previous case study, even though the person was only taking 3 drugs, one for hypertension, one for hyperlipidemia, he was taking Benadryl, and that was a polypharmacy problem. It affected his memory. The top drugs that are implicated for hospitalization of geriatric patients are digoxin, warfarin, insulins, oral antiplatelets, and hypoglycemics. Digoxin and warfarin have very narrow levels of effectiveness versus toxicity, and these other drugs can have side effects such as bleeding, or hypoglycemics such as low blood sugar. So to that end, in 1991, the Beers criteria was developed. This is used to this day by the American Geriatric Society to provide guidance regarding medications that should be avoided in most older patients or in certain situations. A good practice is that when new symptoms are reported by a patient, take a look at the medications first. There's a PDF of the 2023 Beers criteria in the Moodle shell. There's also a couple of other criteria. One is called START criteria. If you see a specific thing in practice, then you prescribe a specific drug. For example, a person who has hyperlipidemia and risk factors for cardiovascular disease needs to be on a statin. Someone who has hypertension should probably be on an ACE inhibitor. If they're a geriatric with depression, they should be on a non-TCA antidepressant. And any patient taking methotrexate should be on a folic acid supplement. Those are just some examples of things that if you see a specific thing, you should start a specific drug. Similarly, there's STOP criteria. The STOP criteria is specific for drugs such as verapamil or diltiazem, stopping those in a patient that has New York Heart Association class 3 or 4 heart failure, stopping SSRIs in patients with current or recurrent hyponatremia, stopping anticholinergic or antimuscarinic agents in patients with dementia or delirium. These are not for you to memorize. The take-home message here is that these criteria are there to assist you as you move through your training as a nurse practitioner and into practice. These are things you'll use every day. Move into depression in primary care. About 20% of adults experience depression at some point in their lives. And something for you to take home, 80% of antidepressants that are prescribed by the primary care provider, and that's going to be us. Symptoms of depression include depressed mood, lack of pleasure in usual activities, guilt, loss of motivation, low energy, sleep and/or appetite disturbances. Depressions can be situational. They can be linked to the loss of a spouse, job, or chronic pain. They can also be longer lasting. Depression that occurs initially after the age of 60 is classified as late life depression. So how do we identify depression? Well, sometimes it's reported by the patient who comes in and tells you, I feel depressed, and they can give you a litany of symptoms. Sadness and wanting to sleep all the time, not much of an appetite. Others, as a clinician, we learn to look at. They are clinical manifestations. For instance, when you're talking to a person and there's no emotion, or they have an excessive concern with bodily functions, seeking reassurance and support. They become isolative or withdrawn. They stop bathing, dressing, brushing their teeth. They feel overwhelmed, easily frustrated, cry easily, or perhaps they're irritable, they're fearful, they're agitated, and they are anxious. There are some tools we can use in clinical practice that are good for assessing the depression level in a person. The Geriatric Depression Scale, the Beck Depression Inventory, the Patient Health Questionnaire called the PHQ-9, and the Montreal Cognitive Assessment for overall assessment. Ask your preceptor what they use to screen for depression. And there's a copy of the PHQ-9 in this Moodle shell for you. That's very commonly used and one that you can become familiar with. Differentials for depression include mood disorders, substance-induced disorders, dysthymic disorder, which is a mild or a longer-lasting form of depression, bipolar disorder, that's a mood disorder, delirium, dementia, and sleep disorders. The goal of treating depression in the elderly is to prevent or reduce relapses and recurrences. We want to keep them in remission from their depression so that we can improve quality of life and their ability to function and improve their overall health. In treating depression, we can look at pharmacotherapy or antidepressants. The selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors have the fewer side effects, and these are the first-line treatment for geriatric depression. The tricyclic antidepressants are not recommended because of their side effects. They are highly anticholinergic, which causes sedation and orthostatic hypotension and can potentiate falling. Something to keep in mind with the SSRIs is that they can cause some GI and sexual disturbances, some insomnia, and we have to watch those patients who are prone to hyponatremia. An SSRI would not be recommended for that person. Additionally, QT interval prolongation or long QT might occur in high doses of citalopram over 40 milligrams. It's important to follow up. An adult with major depression taking antidepressants takes them initially for 4 to 12 weeks. We want to talk with them at least monthly to see how they're doing, if they've gotten relief from their symptoms. If they haven't gotten any relief in 4 to 8 weeks, we may want to change the class of drug or try another drug within that class or add another medication or even add psychotherapy. Psychotherapy such as CBT is very helpful in helping people sort out their feelings and relieving symptoms of depression. Think of depression as different phases. In the beginning, in the acute phase, the treatment is about 3 months, as we said, 4 to 12 weeks. After starting the medication, and hopefully they are getting some symptomatic relief, We want to contact the patient within the first month and every 4 weeks to check on symptoms. Then there's a continuation phase. Once they've achieved remission, this can last between 4 and 12 months. So it's important not to pull somebody off of an antidepressant when they're having a good result from it for at least a year. So then there's the maintenance phase, which is specifically for patients with 2 or more lifetime episodes of major depressive disorder. This can occur in patients that have dysthymia. They should be maintained on medication for up to 5 years. And again, psychotherapy in the form of CBT can be helpful. You can use a scale to reevaluate their symptoms. And consider referring this person or these people to psychiatry, especially when they're not getting better after 12 weeks, or those who are experiencing either suicidal or self-harming thoughts. They need to be sent to inpatient centers for evaluation and management. Other people that you can refer are those with bipolar affect disorder and patients with depression who maybe have other comorbids as well. Some notes about serotonin. Serotonin syndrome is a medical emergency in which there's too much serotonin in the system. The symptoms are agitation, restlessness, diarrhea, twitching, confusion, tachycardia, seizures, and without treatment, death. This can happen from overdosing on SSRIs or taking a supplement such as St. John's wort, which is hypericum, while taking an SSRI. Serotonin discontinuation syndrome is often discussed. This is when a person is trying to get off of a SSRI and they stop it abruptly. SSRIs tend to have short half-lives, and what happens is the person will start to feel dizzy, they'll get a headache, they may have some numbness and tingling or paresthesias, nausea, diarrhea, insomnia, and irritability. Oftentimes the SSRIs, if they're in a large enough dose, need to be weaned off over a period of time. Diogenes syndrome is named after the Greek philosopher Diogenes, who was known for his cynicism and his contempt for social organization and his lack of shame. This complex syndrome occurs primarily in older adults as a constellation of symptoms that include poor insight or understanding of self-hygiene, public health and safety, distrust of society and strangers, paranoia and general suspiciousness, aloofness and detachment, extreme social anxiety. About 15% of the population have Diogenes syndrome. About 36% of those people have frontal temporal dementia. Among these symptoms is hoarding. Social withdrawal, depression, hoarding, self-neglect, and which leads to an exacerbation of underlying medical problems. There's also a dermatological manifestation called dermatitis passivate, which comes from developing layers of kind of thickened skin, which looks like a big callus over their bodies. Treatment, medications for depression and hoarding include paroxetine and high-dose sertraline. Antipsychotics for psychosis and counseling can be helpful. Part of the problem with Diogenes syndrome that goes along with social withdrawal is their refusal of help. Elder abuse is highly underreported and much more common in the community setting versus the institutional setting. This is defined as the mistreatment resulting in harm to a vulnerable person. It can be an intentional or a negligent act. Physical or sexual abuse. It can be absolute neglect, exploitation, emotional abuse, abandonment, and it can be self-neglect as well. When you suspect that a person is the victim of elder abuse, then our responsibility as a healthcare provider is immediate referral. That's either call 911 and report it, or report it to an elder abuse hotline. Grief is intense sorrow and yearning for someone who has died. Bereavement is the process of going through grief, hopefully to some resolution or acceptance. A complicated grief is one in which the person cannot cope with the loss and is stuck in the grief process. Sometimes you can see this in people who have lost a loved one many years ago, but they still go to the grave every day. They still talk about this person and the loss every day. Consider that about a third of people age 65 have been widowed, and that number increases as people age. Signs and symptoms associated with grief are anxiety, depression, impending doom. There can be weight gain or loss, and sleep disturbances. How do we treat someone in active grief? First, we listen. We give them a chance to express themselves and their loss. We make room for them as they grieve. We can also give them emotional support, and we can suggest support groups. There are grief support groups out there. Years ago, after my father died, I joined a grief support group with my mother, and we met with that group for years. Once a month we would go to dinner with the group, and so we stayed friends and acquaintances for probably 20 years. Insomnia is a sleep disturbance. Sleep disturbances increase with age. About 57% of elderly have chronic insomnia. Women, more than men, tends to affect those who are unemployed, divorced, widowed, or of lower socioeconomic status, which sounds like people who have more things to worry about. Contributing factors are restless leg syndrome, which can be quite disruptive to sleep, sleep apnea, dementia, mood disorder, bipolar disorders, caffeine, alcohol, nicotine, a variety of medications. Poor sleep hygiene is pretty key, and screen time. Treatment is first look for underlying disorders. If there's something there to be treated, we can treat it. Work with the person to look at their sleep habits and to develop a good sleep hygiene, which includes shutting off electronics an hour before bedtime, establishing a routine for bedtime, and there are more things listed, but other things that may be helpful are cognitive behavioral therapy, talk therapy. Clinical recommendations are for CBT, mindfulness-based interventions, and we avoid benzodiazepines. Consider medications last, not first. Melatonin receptor agonists can be helpful. Substance-related and addictive disorders are pretty rampant in our society, and the elderly are not spared from that. There are substance use disorders, gambling disorders, and alcohol use disorders. These disorders or addictions are often used to combat feelings of loss, grief, depression, and social isolation. Screening using the screening brief interventions and referral to treatment tool is helpful, and there are 12-step organizations such as Alcoholics Anonymous, Narcotics Anonymous, Gamblers Anonymous, and a host of others that are available and usually easily found by going to the website and finding meetings that are close by.